All right, welcome everyone, and happy Social Work Month. My name is Sarah Sims, and I am the manager of continuing education here at the Brown School at Washington University in St. Louis. Thank you for joining us for today's Open Classroom program. Open Classroom is the Brown School's virtual and free professional development series, which we've been doing since the start of the pandemic, so about 3 years now. But we also do a lot of other professional development. Beyond that, we are the largest provider of continuing education units in both the states of Missouri and Illinois. So if you are a social worker looking for CEUs, or if you are just interested and want to dig deeper into some topics related to social work, I invite you to check out our website. It's brownschool.woostel.edu. And you'll navigate to the resources and initiatives tabs to find all of our offerings. I'm going to drop a link in the chat in just a moment. But we do offer workshops on a year-round basis almost every week. There are 3-hour workshops. And then we also offer more intensive courses. We offer a summer institute and advanced certificate programs as well. So I invite everybody to check those out. A few housekeeping items. We're using a Zoom webinar, which just means that we can't see or hear you, but we do really want to engage with you today. We're going to have a lot of time for Q&A. So please leave any comments, any questions in the chat throughout the time today. You can chat to both everybody here, or you can chat just to the hosts and we can relay your questions. And right now, I will, if you would like to say hello, where you're zooming in from, what you do, where you work, we'd be happy to hear from you. This is also being live streamed on YouTube, which I'll drop a link to that in the chat in just a moment. A recording of today's program will then be posted on YouTube, our YouTube channel, as well as our professional development website. So that's enough of the housekeeping items. So for the meat of today, I'd like to introduce today's speaker, Dr. Trish Kohl. Dr. Kohl is an associate professor here at the Brown School. Her scholarship is focused on strengthening, implementing, and sustaining evidence-based interventions that improve the quality of care for vulnerable families. Through her research, which is informed by years of clinical practice with kiddos and families, she seeks to close the gap between research and community-based practice. Her intervention and implementation research involves analysis of large data sets to examine how characteristics of parents within child welfare service system influences parenting behaviors, child emotional and behavioral health, and the safety of children. Dr. Kohl is currently working to adapt an evidence-based parent training program to increase father participation, as well as to improve father-child interactions. Her work has received financial support from the National Institute of Mental Health and the Centers for Disease Control and Prevention. Dr. Kohl is affiliated with 2 of our research centers here at the Brown School. Those are the Center for Mental Health Services Research, as well as the Center for Injury and Violence Prevention. She's also affiliated with the National Institute of Mental Health's Implementation Research Institute. So today, Dr. Kohl is here to discuss supporting families to promote child safety and well-being. So welcome, Dr. Kohl, and please take it away.
Thank you very much, and welcome. I appreciate you all being here, and do want to start by saying that the panel, as I had envisioned it, wasn't able to come together at the last moment. So I'm going to talk with you around the role of social work in supporting families to promote safety and well-being. And Sarah gave an introduction, but I'm going to also talk about my practice experience and how it's led me to where I am in my work. And with what I'm going to present today. So pre-academia, I actually spent about 10 years as a practicing social worker. I started within my very first job was in a inpatient child psychiatric facility, which really helped me begin to see and pay attention to the intersection of child maltreatment and child mental health. I then spent time in a public mental health center in their family preservation unit, working with families in an effort to keep kids out of the child welfare system, and then moved into a position first as a social worker and then as the clinical director of a therapeutic child care center. And so all of that informs my teaching, my research, and I do some practice still. So through my research, not in direct practice, but through my research, I'm still practicing. And in my research, really a focus on early childhood mental health, on maltreatment, in the intersection with mental health, but also around upstream. How do we work with families, support families to actually prevent adversity, to prevent child maltreatment? I apologize for my dog. There's a FedEx delivery happening right at this moment. He's been being so good until right now. And really around then prevention as well as promotion. How do we work with parents to support parents to help their children reach their full developmental potential? And I do that through, as Sarah said, intervention and implementation work, but also I have multiple studies that are really around community-based participatory work in which we're partnering with parents in thinking about the social and emotional development of kids as well as maltreatment prevention. My hope is today that I'm going to talk with you for about 20-25 minutes. I do want to leave a lot of time for us to have a Q&A, to talk about, to discuss working with families, in supporting families. I will also say I do work both in St. Louis as well as in a global context, so we'll talk about that as well. But I'm hopeful that there'll be time for lots of discussion. And I am going to move to my presentation. I just realized I hadn't started sharing my screen. I'm just talking. Okay. So when we think about social work, children, all children, regardless of where they live, regardless of their race or ethnicity, regardless of their social and socioeconomic status, all children require secure, nurturing, and safe environments in order to thrive and flourish. And I believe it's their right to have those environments. But in order to achieve this, we need both micro and macro social work practice. And so social work's role, we have a role in protecting children, but we also have a really important role in supporting families and empowering communities to help kids reach their full developmental potential, to help kids thrive and flourish. So social work is about promoting child, family, and community well-being, building family and community capacity to help children do their best is really important. But to have strong kids, we actually have to have strong families, and we have to have strong communities. And I believe that is an important role of social work. To help build out community and family, community, and child well-being. I want to say, though, when we think about family, we have to be aware and culturally responsive to the needs of all families that we may partner with. There are an infinite number of family configurations, of family structures. Of course, there's, Ozzie and Harriet, that married heterosexual cisgender couple. There's LGBTQ plus couples. We also partner with single-headed households that parent or grandparent or other kin. When we've thought about single headed households, we often immediately go to single female headed households. But father-headed households, although still relatively small, has been the largest growing group in the last 2 census. So thinking about that, we have to think about our families being led as a gay man, a lesbian. So there's multiple possibilities, endless possibilities, and also that multi-generational household. And so when we're thinking about promotion and prevention and treatment strategies, when we consider the evidence, we have to take into account, has it been shown to be effective with families who are similar in structure as well as race, socioeconomic status, religion, immigration status, sexual orientation, gender identity, across multiple identities? Has this intervention worked with families that are similar to the family that I'm going to engage with? And why would I believe that it is there evidence to support that it would work with the families that I'm currently working with? There are multiple threats to child and family well-being. We know that poverty has a negative impact on child well-being, both directly and indirectly, through its impact on parents and families. Violence, exposure to interpersonal violence, community violence, and school violence. And it's really hard to, we're yet again learning about another school shooting. So our kids and our families and their families are constantly exposed to multiple forms of violence, or the threat of these multiple forms of violence. There's a long list of other stressors: neglect, natural disasters, refugee and war zone trauma, traumatic grief. That all has an impact on kids and how they're doing. But it also has an impact on their parents and their parents' well-being, their parents' self-efficacy, which in turn can impact a parent's capability, a parent's ability to parent their child, to be there for their child, to meet their many, the many needs of youth children and youth who are growing up in adversity. And so we have to, in social work, we have to support parents so they can help their children flourish and thrive. And when and if, we also need to support parents so that when and if adversity happens, parents can serve as a buffer between the children's exposure to adversity and child outcomes. We know there's a substantial body of evidence that demonstrates the important role of that parent as a buffer. When the parent is able to be there for the child, to support the child's outcomes are better. So thinking about families in adversity, not only do we have to respond to the needs of the child, but we also have to be really responsive to the needs of the parents. So as we think about supporting families, there's multiple frameworks for thinking about prevention and intervention. They're called different things. The CDC talks about primary prevention, secondary prevention, and tertiary prevention. The Institute for Medicine, it's universal prevention, selective or targeted prevention, or indicated. And basically these 3 levels, as put forth by the CDC and the IOM, is around that the prevention strategy at the primary or universal is for everyone. It is effort, regardless of circumstances, for all, in this case, families, to receive prevention support, prevention intervention. At that secondary or targeted prevention, it's those families who have been identified as being at an elevated risk for some challenge or problem area, and therefore the prevention intervention is targeted towards them. And at tertiary or indicated, it's already happened, and it's about keeping it from getting worse or recurring. I really like the idea of the sort of Zena's spectrum of intervention that talks about promotion, prevention, treatment, and maintenance. And so in that promotion space, it's how are we supporting kids and families so that they're able to develop competence across developmental spectrums, across their self-esteem, their parenting esteem. At the prevention, it's then very specific to preventing adversity, preventing maltreatment, preventing violence. And so promotion and prevention often go together, but they are really two distinct things. And then there's treatment, that once something has happened, there is a response to that. And I really like that they include maintenance. It's that after there's been treatment, families aren't just, okay, go on your way, but there is some type of ongoing support to help them maintain the gains that they have made. Oh, and prevention, by the way, is the universal. My little arrow just flew in. It's at the universal, selective, and indicated level. But I also want to say, when we're talking about children and families, one of the things that I have found is that the same interventions are often used for prevention as well as for intervention. Many times, interventions that were initially developed to respond to child behavior, to respond to adversity, to respond to trauma, can also be used as an early intervention to prevent child maltreatment, to prevent the development of social and emotional difficulties, dysregulation, to prevent the development of behavior problems. So you'll often see that. And I do think that it's important to, I'm an academic, to look at the research. Has it been found to be effective in both realms? Does it prevention, or are we just talking about it? And does it work as treatment? Or are we talking about it as treatment? So I do think it's important to pay attention to that. So part of what social work is, it's that direct prevention and intervention with children, youth, and families. And I am going to talk about infant and early childhood mental health. That's an area that I do a lot of work in, both from, as I said, both in my practice background as well as in my research. And I really think it's the foundation for which kids grow and develop across their lifespan. And I'd love to see, and it is growing. Social work's presence in this space is growing, but I'd like to see it really grow more. So when we're talking about infant and early childhood mental health, it's not simply the absence of psychopathology. It's not simply the absence of depression or traumatic stress symptoms or anxiety. But kids, young children who are mentally healthy, have the developing capacity to experience, regulate, and express their emotions in socially acceptable ways, able to form both secure adult relationships as well as peer relationships. They can explore their environment and learn. Young children learn through exploring their environment, and they have that trust. I think of from attachment, sort of that security, that secure base that they can go out and explore and trust that they can come back. And all of this happens within the context of family, community, and culture. Hey, so when we think about the role of social work in early childhood mental health, there are a few roles, jobs, however we want to talk about that really come to mind. And one is the infant and early childhood mental health consultant. There are multiple models of this. Georgetown has hosted the and does the training in the initial infant and early childhood mental health consultant role. And it's really about establishing between the consultant a collaborative relationship between, it's often done in childcare settings. So these mental health consultants come in, they work with childcare center administrators, they work with teachers. How can they create an environment in which all children in that classroom do well? That they're able, the teachers are able to meet the emotional and behavioral needs of all of the children in the classroom. They also can do consultations specific to individual children who are struggling. And so working with teachers, working with the center on how do they create an environment in which that child can succeed. Consultants can work with home visitors, so who are going into the home that may not have the expertise in early childhood mental health. So some mental health consultants actually work with home visitors. The goals of this intervention is really around addressing the factors that contribute to a child and family's difficulty engaging in the early childhood setting. It's typically provided to staff and families, and I just said that. And there's modeling and coaching so that the consultant can model for the teachers, and then they coach the teachers. The next step is really coaching the teachers on those skills that they're learning. They provide education on early childhood mental health, and they provide advocacy for families. The goals are to prevent preschool suspensions and expulsions. Now, I know it's been a long time since I worked in the therapeutic child care center, but it was really eye-opening for me, the number of preschool and then kindergarten suspensions and expulsions that happened. It's about improving didactic relationships between the teacher and the young child, between the parent and the young child. And one of the outcomes has been reduced missed work days for parents, because their children are doing better within the child care setting. They're not expelled, they're not suspended, or their parents aren't being called in for consultation to talk with their children, or talk to the teachers and the administrators about their child. So it's really exciting. And I've seen a rise in the number of infant and early childhood mental health consultants in the last few years, which is really exciting to me. Also, therapeutic childcare centers. And as I said at the beginning, I spent about 6 years practicing within one, first as social worker and then as clinical director. And in this model is that the young children are within the childcare setting for at least 4 hours. In our setting, we worked really hard to be able to extend that in case parents were working, but they were there for at least 4 hours. There's academic, emotional, and behavioral interventions that happened within the classroom. So I often think that in my role within a therapeutic childcare center, we were sort of that built-in infant and early childhood mental health consultant, that we were in the classrooms working with our teachers on how to create an environment for success for everyone, while at the same time providing individual level interventions. Within therapeutic childcare centers, there's also a home visiting component. It's not just that the child comes to the center, it's that the social workers are making home visits, are working in the home with the families, jointly looking at what are the goals for the families and supporting those families in that work. Some of it for me required therapy with parents separate from work with the children, required work with the child and the parent together, and sometimes it was referrals for more intensive therapy. And then when I think of the early childhood mental health specialists, one of the interventions that comes to mind for me is child and parent psychotherapy, which was developed by Alicia Lieberman, and it's an intervention. It's a psychodynamic intervention that is really helping families to heal and grow through stressful experiences. When there has been trauma that has impacted both the parent and the child, for instance, intimate partner violence towards the mother that the child has witnessed. Both have had these traumatic experiences, and this intervention actually works to heal that relationship, to heal that trauma, and help children to feel safe with their caregiver, help both the parent and the child to make sense of what they had went through, and to learn strategies to cope with negative emotions, and then to build healthy attachments. So there's a lot of really exciting opportunities and work that's happening within the early childhood mental health space. When we think about young kids into middle childhood, and I will actually say teens as well, the work that I have done has been in this 4 to 12 space, but there are also behavioral parent management training programs that have been developed specifically for teens. So this does translate there. And these are when a child is demonstrating behavioral problems. These interventions target the parent, and by changing how the parent responds to the child, we ultimately change the child's behavior. So is actually then the recipient of the intervention. Now, some of these are done with the parent and child together. Some of these are done just with the parent, and there are the demonstrated effectiveness has really grown for these. We hear a lot, parent-child interaction therapy has strong empirical evidence, both as mostly as a treatment. There is I'll talk about it as a prevention in just a second. Triple P has a range of interventions that go from prevention to treatment. It can be done in group. It can be done in the home. Some of the Triple P variants have the parent and child together. Incredible Years is another parent management training with strong effectiveness, and that's a parent intervention. The child has a separate intervention. I'm going to come back to parent-child interaction therapy. So that was developed specifically as a treatment for the prevention of disruptive behavior. So there's externalizing behavior problems. It has shown to be effective in responding to and preventing child maltreatment as well. I have a colleague actually in the School of Medicine in Psychiatry here, Dr. Joan Luby, who has adapted parent-child interaction therapy to add a emotion development component that targets emotion regulation and dysregulation. And then together we have shortened that and have pilot tested it within one school district in the St. Louis area, and are hoping to test it with a larger sample, looking at it as an early intervention prevention that is a shortened version that's really focused on that prevention component. So fingers crossed that we're able to advance that. Excuse me. Advance that work. Come on. Okay, I'm going to stop sharing it for a moment and come back to sharing my screen. Sorry about this. Okay. Here we go. Let me scoot through this. Sorry. It got froze. It froze. It got froze. It froze. So I think that one of the exciting things with COVID, we had to adapt very quickly to telehealth, to virtual service delivery, and barriers that were in place pre-COVID were able to be overcome. Took some learning curves, took some trial and error, but it did in fact force the use of telemedicine and virtual platforms, and we found that we could do it and that parents liked it. And I have some work I do, some evaluation work that I do with one of the interventions is parent cafes, which is a early prevention family support approach that is about increasing protective factors and reducing risk factors, that was developed as an in-person face-to-face intervention and had to quickly move during COVID to virtual. And one of the things that we have found is parents don't want to go back. And it's and that's the same thing that happened in our when we were testing the parent-child interaction intervention within the Jennings School District during COVID, is we had to move to a Zoom platform, and we actually got better outcomes on Zoom. Parents had fewer distractions. They were able to get there and found they really liked it, and so are continuing in that modality. So social work is also about economic and concrete supports. It's about policy advocacy. We know that there are economic supports that reduce the risk of child maltreatment and improve child development outcomes. So we need social workers that are doing policy advocacy work, that are working to increase access to these economic supports. And there's a policy framework that I really like that I'm gonna talk about, and that's really a family focused. These are come from Karen Bogenscheider and Elizabeth Gross, and they have a strategy that's called the Family Impact Seminars. And I love their family focused policies, because that is about they're achieving, it's can be explicit or implicit. So explicit policies about family are designed to achieve specific goals regarding family, but there are also a lot of implicit policy that aren't specifically or primarily intended to affect families, but have very direct consequences on them. And it's important both that paying attention to the explicit and implicit policies. And a policy that derives, they talk about family policy as one that derives from 4 functions: family creation, economic support, child rearing, and caregiving. And I want to be really clear that when we talk about family creation, we're not only talking about that nuclear family with a male and female identified at birth, having children, but it's about opportunities for other families, opportunities for LGBTQ plus families to parent, to foster parent. All of those our policies are also around family creation, as are policies around an individual's choice whether or not to have a family or not. And so thinking about policies from that perspective. And in order to do so, excuse me, we need to pay attention to family trends and what are their impact for policy. What are their implications for policy? What is the impact of actual and proposed families on policies? There's often unintended consequences associated with policies. What are those? Social workers, we need to be gathering evidence on the effectiveness of family-focused policies and programs, as well as the ineffectiveness, can I also say that? And the implementation of policies, and doing so in ways that respect families and support their well-being. So policies, even the best policies, if they're not implemented correctly, may not have the intended consequences. So that implementation of policy is really important. We want to pay attention to the consequences for families, whether it was explicitly or implicitly aimed at families, and thinking about how the circumstances that families are living in may contribute to what's going on, how families are affected by problems, and they actually say whether families need to be involved in solutions. And I don't ever believe that's a whether. Families need to be involved in solutions. We need to be doing this work, engaged with families, engaged in partnering with community. Of course, there's concrete supports, and as social workers, we need to be involved in building out the capacity of our communities to provide supportive housing, to provide rent and utilities assistance, food and clothing, appliances, etc., so that there is access when families are in need. And I do just want to, I'm going to talk about one specific, very quickly, oh my goodness, I just looked at the time. A study that is going on that's called the Babies First study, and it is really about the value of unconditional cash assistance for young kids. And they have found that when families received, and this was low-income mothers, when they received $333 a month compared to, I think it was like $25 a month was the nominal condition. Over the first 40 months of their children's lives, they have shown improvement in actually their brain activity of those children. And they're in the process of looking at other outcomes, but it is really promising. And when we think about the other costs that this is preventing around the special school district, around special education, around mental health, around physical health, around juvenile justice, adult justice involvement. The $333 a month is actually a pretty low investment for pretty substantial outcomes. I'm going to talk really quickly so we can go through, we have time for questions. But it's also in macro. It's at the macro level is also really, really important. And thinking about within that, there's the Parents and Children's Together St. Louis project that the Vision for Children at Risk is actually is hosting. It's within their organization, is really looking at multi-level strategies for supporting families, for building the capacity of our community to better meet the needs of families, and so that services are not siloed. So it's targeting these multi-level strategies, or it's incorporating these multi-level strategies in order to get better outcomes, not only for kids and families, but for communities. And I think it's a great example of a community-based intervention. It's also really important to think about trauma-informed community building, and social work is should be a huge part of this. Because there are a lot of challenges that communities that have been impacted by trauma face, and those are listed here, and so there needs to be supports and strategies in place to overcome some of this. And so the principles of trauma-informed community building is do no harm. We have to recognize the past and current trauma that community has experienced, and at all costs avoid re-traumatizing individuals in the communities. We have to meet families. This is social work 101. Meet residents where they are, accepting the realities of community conditions. Empowering the community, including them in all aspects, in ensuring that they have equitable participation, and that it is an ongoing reflective process as well. And I'm gonna, social workers are also working in the global arena. One of those areas is around integrated parenting interventions. Speaking of siloed services, so often in countries where children are at high risk of stunting, high risk of being malnourished, having poor developmental outcomes, interventions are often siloed. That we have nutrition interventions, we have WASH interventions, which is clean water, sanitation, and hygiene. And then we have early learning or responsive parenting. So parenting interventions and early learning interventions. And what these integrated parenting interventions, and we're currently testing one with 600 families in Cap-Haitian Haiti, in northern Haiti, is that they bring together all three of those areas. So in this 12-week intervention, parents are mothers learn about self-care. They learn about child development. They learn about that parent-child interaction. They learn about reading to their children, or talking to their children, singing to their children, dancing with their children, making toys to help their child's development. While at the same time, they learn about introducing healthy complementary feeding, or starting at age 6 months, as babies are moving away from exclusive breastfeeding into the introduction of other foods. And then there's clean water and sanitation and hygiene intervention, violence and injury prevention, social and economic development, and intervention and support with immigrants and refugees are just some of the examples. And I want to, from a prevention of childhood violence, I really like the strategic framework that No Violence in Childhood put forth. And it's, in order to prevent childhood violence, we need to enhance individual capabilities. So we need to equip parents and other caregivers with the skills that they need in order to meet the needs of their children, in order to be responsive to their children's behaviors in a nonviolent way. There is then eliminating the root causes of violence. So not only working to stop the violence, but address those root causes within the environment, within the social norms. And then embed violence prevention within institutions and services so that it is everywhere. So that's just a model that I really like, that I actually believe it was developed for a global framework that is really important in a US context as well. And I went longer than I wanted to before opening up for questions. I apologize for that. But I'd love to hear some questions and have some dialogue.
Yeah, great. Thank you. Thank you so much. I really appreciated this presentation as the parent of 2 young children. It's so helpful to hear your perspective and your work. So I've got a couple in the queue that I'm going to ask, and then please, others, if you want to add your questions to the chat, you can do so. So first, this is kind of like a just follow-up question on the therapies that you shared about. We have someone who said, I hear a lot in practice that the parent-child interaction therapy, PCIT, providers only provide for children up to age 6 or so. Is it actually available up to age 12, or is that a different version of parent management training?
So that is a great question, and PCIT is usually done with younger children, incredible years, and in Triple P, as well as some of the other, have variations that work well in that middle childhood and then the teenage and then in the teenage year, that as kids hit 8, some of the activities in PCIT really aren't developmentally appropriate. The work we're doing in the school system is actually with preschoolers through 1st graders. So that's a great question. I should have been more clear on that. Thank you.
Yeah. And then another question about PMT, parent management training. Could you give some examples of some of like the specific parent behaviors that PMT addresses or teaches?
Absolutely. So, and we could actually taught a 15-hour course on it. So we could spend a long time on this, but I'll give a brief overview. So parenting is actually, when we think about parenting, it's very complex, but it's at its simplest form, it's this 2-prong construct that you have, on one hand, relationship based, that nurturing, that warmth, and then on the other, the other prong is monitoring and supervision, that response to children's behaviors. So one of the commonalities across all of the models is focusing first on that parent-child relationship. And so some of the skills, I have done research with all three of those models. I'm gonna use and they have the same skills. They all say them a little bit differently. I'm going to use the triple P language around that. And now I'm drawing a blank on the exact name. So in terms of relationship, it's praise. It is descriptive praise. So it so often, particularly by the time we see families when there's a child with a behavioral problem, parents can't see the good that their child does. So it's starting with things like finding something to praise the child for, even if it's the tiniest thing. Because one of the things we know is kids are often acting out in order to get attention. And so by helping parents give them more positive attention earlier on, or give them attention for positive things, one of the things we find is just in doing that, some of the negative behavior, the disruptive behavior of the child stops, because they're having those needs met. So it's descriptive praise, it's quality time, reading, playing together, spending time together. And it's more about quality than quantity. If you don't have 4 hours, but you have 15 minutes that you can spend reading a book with the child, spending time with the child, it's those skills, and in helping parents practice. All of these have practice components, and they practice during role plays. And one of the things that I will say, I have used Triple P. We adapted it with African American fathers in the city and in North County, and I would have sworn that one of the adaptations we were going to have to make is that we were not going to be able to do the role plays. They had so much fun with the role plays. So we can't assume in terms of the practicing. And then that second piece is introducing more positive discipline strategies. Being consistent is a huge one. Clear instructions. Oftentimes parents, we give six things. You need to go upstairs, take your book bag upstairs, wash your hands, come back down, set the table, then go get your brother. So instead, so giving directions that are clearer, that there's fewer steps within those directions. And then there is there's a lot of controversy around timeout, and really the need for time in instead, that it's really about that connection. And so I will say that is one of those pieces that I personally am reevaluating. However, they also include sort of quiet time, because ultimately I have to say, we want kids when they need to, we want adults who can regulate themselves. So we actually want kids and adolescents to identify when they need to take a self-time out to regroup. So but there are those different strategies there. And I want to come back to, there's so many. There was the question on institutional racism that I want to talk about.
Yeah.
Find it now. Can you?
I got it.
It went past me.
So this is kind of a comment that, hopefully you can comment on more. It says, I think that especially here in St. Louis, but in other areas we know throughout our country, we need to look at the impacts of institutionalized racism in terms of ongoing trauma, as well as responsibility for community conditions. So that was a comment, but I wonder if you want to speak more to that from your perspective.
That is absolutely critical. And one of the things with the parents and children together, work that I'll speak to. It's an example of the ways in which we're doing this. I love the framework by Fine and Torre, which is critical participatory action research. That we're not just doing research to do research. It is partnering with the community, partnering with providers. We actually frame them sort of as co-researchers, and they are, and it's about centering their voice, and that's about trust, respect, valuing, elevating their voice, because, and they have shared with us that whether it's within child welfare, whether it's health, whether it's concrete services, wherever it is, whatever services, it's not, unfortunately, it's not a single service that families are experiencing racism and bias, which one of the things they've shared with us, which often leads them to just disengage with services that could be supporting them. So it is absolutely critical. And so in the work with Parents and Children Together St. Louis, which PACT STL, we feed this back. We feed it back to the providers with parents present. We have those conversations with parents, our Parent Advisory Council, who are part of the PACT collaborative, and have conversations where this next phase of the project is, hopefully we're waiting on some supplemental funding. That's the story of my life. Fingers crossed on this one as well, in which we're actually going to look at policies that are implicit or explicitly contributing to the experiences of African American parents. So what? Because one of the things we know is that there is bias in our policies. That are driven by institutional racism. We have a framework that we look at for that project that that acknowledges at the individual level, at systems theory, at the individual level, that the families that we are partnering with have in fact experienced racism, have experienced bias, that is not in question, that is in fact a fact. Their communities are marginalized. The communities in which they're living are marginalized. They have experienced harm as by research, and so we are absolutely cognizant about that, and working to redress that. I'm paying attention to time. I could go on, and I'd love to have further conversation around that. That is something we're being very, very intentional with. Okay.
Yeah, that sounds great. I mean, what I hear you saying is, just to kind of put it simply, is, the difference between doing something for or to a community versus doing something with the community, right? Like partnering with community and
absolutely. Family. And I do want to add one more thing. And I think that for instance, in that project, the target communities were identified through those traditional risk factors, those risk indicators that are there. Part of our story, though, is acknowledging in all aspects that those communities, those zip codes, are not disproportionately African American because of anything that those families have done. They are disproportionately African American because of racist policies that are grounded in white supremacy, and owning that. And part of our goal then within this project is to represent those communities based on their many, many strengths. Those risk indicators don't describe those communities. There's so much more. And how do we elevate that story, that narrative? Okay.
Last question we'll squeeze in here is on just a global perspective, your perspective on how to support parent-child relationships and to empower parents in the welfare context. So are those therapies, is there something that should be standard in welfare cases on, from your opinion? How can we empower and support traumatized parents and children to engage as quickly as possible to return children as quickly and safely as possible in that context?
That is a absolutely great question, and I understand that people may have to hop off. We're at time, but I will. I do want to spend some time with that. And I first and foremost, I believe that we have to invest more upstream. We have to invest in these community supports, so we're keeping families out of the welfare system, the child welfare system. When they are identified and come in contact with that system, we need to increase access to culturally responsive, evidence-based interventions that are effective and work early, to then keep kids out of the foster care, and certainly when they do move into foster care, we have to intervene with the biological parents as quickly as possible so that child is reunified whenever possible, or moved into permanency really quickly. My hope is that as we invest more upstream, we will have a smaller child protective service system, a much smaller foster care system, in that most cases, most situations can be addressed within the community. That's my hope. I do think we will always need to have, unfortunately, there will always be cases that we need that full protection for kids, but we need to do better upstream supporting families to keep it from happening as much as possible.
Well, thank you so much. I know we're a minute over time here. I really appreciate all of your presentation, your answers to the questions today. I appreciate the audience members, your questions that produced such a fruitful discussion at the end. We will be posting the recording on our website. I put a link to the chat. And then Dr. Kohl, are you comfortable sharing your PowerPoint slides as well?
I am. I'll send those to you. I'll send them to you as soon as we're done.
All right. We will also get those posted on our website, same link that I put for the recording. So thank you, everybody, for joining in today. Have a wonderful rest of your day.
All right. Bye-bye.